sedation, he was on midazolam because he had had some electrical burns, and I think he had a threatened airway and he had an endotracheal tube in. And so that's a patient you want to be sedated. You don't want them to pull their tube out. Maybe if they're difficult to ventilate, you want to make sure that you've sedated them. And if they have a high ICP, and you get a lot of head injuries here, don't you, and strokes, if someone's got a high ICP, then you want to make sure they're well sedated. And so that's useful, and it reduces their oxygen demand in their brain. But the rest of the time, for everyone else, you really don't want too much sedation. And if possible, every day when I do a ward round, I will want to go around and stop the patient's sedation. And the best thing is if you have a nurse that will stop the sedation before you even get there. Because they say, oh, the doctors are coming around now, I'm going to stop the sedation, so that they can assess the patient on the ward round. And then that way you can see what your patient's doing. And sometimes once you stop the sedation, a lot of things get better. The blood pressure comes up, the patient starts looking around, they can cough, they can get secretions up, they can move around. So, the noradrenaline comes down because you don't need it anymore because a lot of that was because of the sedation. Yeah? And sometimes we joke, oh, it's nice to have a patient that's sedated. Because it is nice, if the patient is flat and they're not doing anything. But it's better for the patient if they can move around and wake up, Yeah. Because the other thing is, when you're doing sedation, you also want to check with your patient, do they have any pain? A lot of patients on ICU have pain, and always it's good, and I'm sure you do this, to come up to your patient and you speak to them, say, hello, my name's Simon, I'm the doctor, I'm your doctor today. You're on the ICU, you're nice and safe, and, how are you doing? Do you have any pain? And, they may just shake their head, no, I don't have any pain. Or maybe they have some pain, and then, you can do it. Even with a tube in their mouth, if they're awake, they can tell you what's going on. Yeah? The other thing you want to look out for is, has your patient got delirium? And delirium is very common on ICU. And we know that patients who have delirium are more likely to die. Patients that have delirium are more likely to have ongoing cognitive issues like a year down the line. So you want to look at, check to see. And what we try and do twice a day is do a CAM ICU score. The nurses do the CAM ICU score, and they check to see, does the patient have delirium? And then maybe we can try and help. And it's hard. ICUs give patients who are sick and patients on ICU, they get delirium. And if possible, we're trying to make sure that, we give them reassurance, that we're kind to them, that we reassure them, and we try and minimize anything that might give them delirium, yeah? So partly you want to make them better. So if they've got bad pneumonia, then if you make the pneumonia better, the delirium will get better. And maybe we'll try, if we've tried all those things, maybe we'll try something if they're very agitated. So sometimes we will use drugs like olanzapine or haloperidol. I don't know if do you have haloperidol here? Yeah, we'll often use that, yeah. But if possible, we'll try and minimize the sedation. And the other big thing that we need to worry about is we try not to use too much muscle relaxant. So if the patient has bad ARDS, they're difficult to ventilate, or they have high ICP, then you'll sedate with muscle relaxant. But the rest of the time, we'll try and not have any muscle relaxants. Yeah. So because we know that if you give a lot of sedation, a lot of muscle relaxant, patients will become weaker. And I don't know if you've seen this, I'm sure a lot of you have who do a lot of ICU. If you have a patient on ICU for some time, a week or 2 weeks down the line, they're losing muscle, they're losing bone density, they become weak, they get a critical illness neuropathy, yeah, and myopathy. Good. Yeah. So what we want to do, and the other good thing that we can do if we're a good ICU and we're giving good high quality care, we want to say, what sedation score do we want for our patient, yeah? And so a lot of ICUs will use the RAS score, this score, and what score do you think you want? What would you like for yourself? You've got a choice. Elias, you're here. Which one do you want? Do you want to be combative? No. And you don't want to be unrousable. Yeah. Ideally, you want to be like 0. Yeah. You want your patient to be calm and alert. And you can often, if you're on a good ICU, your sedation has been stopped. Your nurses have stopped the sedation, and your patient is, desedated. They're being reassured. They have a tube maybe in their mouth. They're on a ventilator, but they're calm. Yeah. Good. And we have to remember, a lot of the drugs, there's lots of different types of sedation that you can use. And I know that you guys use propofol a lot here, and sometimes we'll use, other drugs that are longer lasting. So if you're using midazolam or morphine, things like that, you have to remember if your patient's sick and maybe they've got renal impairment, these drugs are going to last for a lot longer. So sometimes we have patients in Australia that are flown from the other side of the state. It's a very big country, and they will be on a ventilator on an infusion with morphine and midazolam, and we stop it and they'll take a day to wake up. So as soon as they come, we try and stop it. Yeah. And like we were talking about this just now, sedation will like drop your blood pressure. Definitely benzodiazepines are bad for you. They can they can increase your risk of delirium. So that if possible, we want not as little sedation as possible. Yeah. Good. Anything else about sedation that anyone wants to talk about? No? So in the fast hug, that's like feeding, analgesia, sedation. That's the sedation one. And I try in my head. Some places will have a checklist. When you go around each bed space, you have a checklist or a tick box. So have you thought about this? Have you thought about that? Yeah. So in terms of nutrition, when would you want to feed your patient? If you say you have a patient with pneumonia and you've just intubated them, and now they're there on your ICU, when would you like to feed them? I can't pick on you again. No. When would you like to feed them? Would you like to feed them now or in a week? Tell me. Now or in a week? You want to feed them as soon as possible. If and most patients, they should have some food, and the best food they can have is going down into their stomach. Yeah. And some patients who are very sick, when they're on very high levels of inotropes and pressors, you might decide not to give them too much food for the first day or two, or you might decide to just do a little bit of food, 10 or 20 mils an hour down the enteral feed. Yeah. But if possible, you want everyone to start feeding early. Yeah. And that's a good thing because it's good for your gut, your gut wall. And we know that patients that are not fed, they get villus atrophy, and you can get translocation of bacteria across your gut. So everybody should have. I had an old boss, that very famous guy, Finfa, who did lots of big publications in ICU. He said everyone should have some food. Yeah? Yeah. So enteral food if possible. Yeah, so you're just seeing there. So you can also have parenteral nutrition, obviously, feeding into your vein. But if possible, we want to give patients enteral nutrition. The problem with parenteral nutrition is it costs a lot. You're more likely to get like line infections. So enteral nutrition is the best thing. And then what I saw on your ICU here that there was some food there ready for the patient, and somebody had. I'm not sure who does that. Is that a dietitian or the nurse? Who does it? The doctor and the nurse, and do you have a dietitian as well, or nutritionist? Okay, yeah. So and they you want to get the right, see how many calories you're going to give your patient, yeah, how many kilocalories, and then you're going to give them a mix, aren't you? Some carbohydrate. There's a lot of carbohydrates here in the food. I noticed. It's nice. The cassava. Yeah. You want some carbohydrates. You want some fat, less fat, maybe 30%, and you want some protein. Yeah. So what? Maybe 1.5 grams per kilo, something like that. Yeah. I think it's not that important in a way what that is. I think the most important thing is that you're giving your patient some food. Yeah. This is all complicated. I always get confused by all this stuff, but I'm lucky I've got a nutritionist too. So, yeah. I'm like, we need to. I know we need to start feeding the patient. Yeah. Good. Yeah, so like we said, you want to do it when your patients, if their patient's very unstable hemodynamically, some people will not feed their patient initially. But it's so good for you, in terms of, especially if you say you're a post-op patient, they're going to heal better if they're getting food, yeah? Yeah, and so I guess you're going to feed them down the nasogastric tube. Who puts the nasogastric tube in here? Do the nurses or the doctors? Nurses. Oh, that's so good. Yeah, yeah. And how do you know that you're in the stomach? How can you tell? You aspirate, and how will you know that it's not the lungs or the... What if you only aspirate a bit? What do you do when you aspirate it? How will you know? Pardon? Yeah. Okay, yeah. Do you ever pH test it or?
Sometimes.
Yeah,
Yes.
yeah. I think you want to be careful because what do you want to make sure never happens? You don't. What don't you want to do if your NG tube's in the lung? You don't want to put any food down it. Yeah, and that has happened in my country when people didn't like check that definitely. So people listen and they think that they can hear air in the stomach, but they're not. It's not right. That's not a good. That's the wrong. You shouldn't do that. Yeah. So what you should do is either pH test it if it's a low pH, or you should get a chest X-ray. Yeah. That we would do a chest X-ray, but I know a lot of countries will just do a pH test, but that's still good. Yeah. Yeah. So has anyone ever done that? Pardon? Did you do that? Has anyone ever put it? I've done it before. I mean, I think it doesn't matter if you put it in the lung, as long as you don't put any food down it. Yeah. Okay. Good. And so you're going to start. I know some places will bolus feed, and some places will start, at a slow rate. When you're giving food down the NG, do you aspirate it every now and then? Yeah. Yeah. And what happens if you aspirate 300 mils? What do you do? Do you have a protocol or?
See if there is digestion.
Yeah. Yeah. Give it back. Yeah, yeah. So we have a protocol that, you're allowed to have quite high aspirate and then you can give it back, to the patient. And you would only stop the NG feed or reduce it if it's like 500, 600 mils of aspirate. Yeah? Because everyone's got, if we all have an NG tube in now and we aspirate, we all have food, we would all have gastric contents. Yeah? Yeah, good. Yeah. Yeah, and sometimes you do find that patients will have issues with their, they're not absorbing. So maybe you reduce the rate, yeah? Or you can start different medications. Do you ever start medications to improve your absorption? What would you give? Yeah, would you give any medication to try and improve absorption or? Yeah, you can give like metoclopramide is like we would use, or erythromycin. There's different ones for absorption. Yeah, yeah. Obviously, if your patient is sat up, then it's going to be easier for them to absorb. Yeah. And sometimes, a diarrhea in patients on ICU is common. It's mostly it's not the food, but I guess you always need to be worried. Do you have much C. diff here? Clostridium difficile, diarrhea, C. diff diarrhea. Yeah, yeah, we have quite a lot. We probably use too much antibiotics. Yeah, so if you use a lot of broad spectrum antibiotics, you're more likely to have C. diff, and that's why we have to be so careful to wash our hands, especially for doctors, because doctors move between the bed space and they can bring bugs along. So our nurses will tell us to wash our hands. Yeah, yeah. You should make sure when you go back to your unit to tell your doctors to wash their hands. Yeah, yeah, because I don't want to make my patient even more sick. Okay, good. Yeah. So, and DVTs, that's another one part of the fast hug. They're pretty common. What sort of things would you do to stop people getting a DVT on your ICU? What would you do to stop them getting a DVT? What can you do? Yeah, yeah, you want them to move about, so I guess stopping the sedation and making sure they move. And also if you're on ICU and we have some physiotherapists, good physiotherapists, they will try and get our patient out of bed. Yeah? Even sometimes when the patient is on a ventilator and they're on dialysis, they will try and move the patient out of bed, and put them into a chair. Or even if they've just had a big heart operation, we'll try and walk the patient down the unit. Yeah? They'll have drains everywhere, lines everywhere, but we'll walk them, make them move. Yeah. It's not a holiday. They have to work. Yeah? Good. And what other things can you do to stop clots? You know the answers to this. Where are my doctors? Where are they? Innocence. What can you do to stop clot? Pardon? Yeah, thromboprophylaxis. So what do you use? Do you use heparin or Clexane or? Clexane, that's good. That's good. We're starting to use Clexane more, but traditionally in Australia we use heparin, which is not actually as good as Clexane. Yeah, maybe it's better to use Clexane. I guess as long as they don't have a contraindication. The unit I work on has a lot of patients with subarachnoid hemorrhages. So in the first 24, 48 hours, we don't give them any. But once they've had the lesion coiled, the aneurysm or clipped, then we need to remember. The other week, I had a patient a week in, post-subarachnoid hemorrhage, getting better, and I realized that she wasn't on any heparin, which was a big mistake for us. Yeah, a big mistake. Good. And then do you have these sort of things, like the calf compressors or TED stockings? Yeah, you have the TED stockings, that's good. Yeah. And then one of the other things you want to think about, all these little things that are important, a lot of these patients will get stress ulceration, yeah, because, and before we knew about it as much, a lot of them would get big GI bleeds on ICU. So what sort of things can we do to stop them getting stress ulceration? Pardon? Exactly. That's the best thing. If you can feed them, then you're going to stop them, getting... And in fact, we will put our patients on pantoprazole or a PPI, every patient that comes in. But as soon as we're feeding them, we should probably stop it. Yeah? Do you use ranitidine or pantoprazole or what? Pantoprazole. Okay, so that's the same. Yeah. Mm. Good. Yeah, so it's all, I think some people think it's a bit boring, all the little housekeeping bit. It's the bit I like the best, because I think that's where you can make the biggest difference, Yeah. Does anyone have any questions? No? Anyone want to ask anything about any of those things? No? So we just talked about a few of the things in the fast hug, but when you go home today, have a look about, if you Google fast hug or fast hug in bed, and when you're on the ICU, the next time you're at work, have a think, maybe you already do it, but you have a think about how you can check off for each patient, that you're doing all the things you should to make it the best quality care, yeah? Yeah, so thinking about sedation, delirium, thinking about your nutrition and thinking about, DVT prophylaxis and things. Good. Finished? Yeah? Where's my clap? I'm clapping. Oh, very good. Yeah.
Hello? Can you hear? Okay. The aim of doing it together is so that we can all learn together. All right. So I'm going to start mainly talk about how we would transport ICU patients, what we would consider, how we'd plan and prepare, and then Dr. Chunga here will add in a little bit more about patients in the emergency department and what you need to consider. So, yeah, so hopefully we're just going to go through which patients we will transfer, why we will transfer, weigh up the risks of transferring versus keeping them in your hospital or in your department, and then how we prepare for that to do it safely. Okay, so why do you transfer patients? Obviously, if you're transferring from the emergency department to the ICU, of course your patient needs to go because they need more advanced care and ICU level interventions, which obviously you can't keep in the emergency department. But if you're a patient in ICU, some of the reasons why we transfer them out of ICU is because they need a CT scan or they need to go to theatre for a procedure. Or in some situations, some hospitals don't have everything there and they need to go to another hospital to go and have their brain operation or their open heart surgery because my hospital doesn't have it. So then I have to package my patient from ICU to be able to safely transfer to another hospital so that he can be cared for over there. Okay, so these are generally the reasons why we would transfer patients. And on the odd occasion, there might be a patient that's on holiday in a different country who has got sick over there and needs to be transferred back to their home country. So sometimes we have to do an inter-country or international transfer. Okay. Usually we're not the people involved in those. They have special teams for that. Most of us are really only going to be transferring our own patients either within the hospital or to another hospital. Okay. So, risks and benefits. What are we going to consider? And the most important thing is, why do I need to transfer this patient? What is that other place going to do? Is it important for the patient to go to another unit or to go for the scan? Is it going to help me, look after them a bit better? Is it going to give me more information about what's happening to the patient? So if that is really the really important thing, then I'm going to make it happen. Okay. But you have to always know, whenever you transfer a patient, you're going out of your environment and you're going into a new environment, which could be an ambulance, it could be an MRI scanner, where you don't have any people around you, you don't have any familiar equipment, and if something happens, it could be really messy and your patient could die. So you have to really decide, is this important for the patient? Okay, yes it is. If it is important, is this the right time to do it? Or is my patient too sick today? I might have to wait till tomorrow. Okay, and so you have to weigh up all these things. So sometimes your patient is too sick and you cannot move them because actually you're probably going to do more harm. So you have to weigh up all these decisions when you make that, a final call about transferring a patient. How many of you here have been involved in transfer of critically ill patients around the hospital or into to another hospital? Hands up. One. Anybody else? Two. Yeah, excellent. So, it's not uncommon, and so I think it's really important to be prepared and just know how to prepare. So I've talked about where we would normally transfer our patients, and now we're going to talk about, what do we need to think about. So if I give you a scenario where I've got a young patient who has basically got, has come in unconscious and has been intubated, and we don't know why this patient is unconscious. Okay, so we need to transfer them to the CT scanner. But they're also hemodynamically very unstable. Okay, they're on a lot of noradrenaline, they're on a lot of oxygen as well because they've aspirated while they were unconscious, and they're on about 65% or 70% oxygen via the ventilator, and their SATs are only 90%. Okay, they're on a lot of noradrenaline to give them a blood pressure of 90 to 100 systolic, or a MAP of 60 to 65. Okay, so you have to think, okay, how many of you think the scan is important and we must do it for this patient right now? Hands up. Anybody thinks we should take this patient to scanner now because we need to? I think so. How many think the patient's too sick to go right now? Nobody. Okay, all right. Well, the patient is sick, but we can't, if we don't know what's going on, we can't really do a lot to treat and make them better, because if this young patient has had a bleed in the brain, there's a treatment for it, which is to go to theatre. And if they can do that, she has a chance to survive. So we need to know what the problem is. Okay, so it's going to be a risky transfer because I know this patient is very unstable, but I also know that if I don't find out what's going on with her, she may not survive if it's too late, yeah? So I need to plan, and I'm going to think, okay, I need to take her for a CT. These days CTs are very good, and you can probably do, the actual time it takes to do the scan is maybe 5-10 minutes max. Okay, so scanning is really short. It's taking them there, putting them on the table, taking them off the table takes a lot longer. So I know the scan time is short, so it's actually manageable. First thing, okay, my environment. Do I know where my CT scanner is? It's in the other part of the hospital, or is it nearby? Do I have to go up 8 flights of stairs, down a lift, you know, down a corridor? What's my environment like? Okay, so I need to think about that. And what time of day is it? If it's in the middle of the night and it's just me, if I'm going to take this young lady to the scanner, who's going to look after the rest of my patients in ICU while I'm away for an hour or two? Okay, so you have to think about those things. But if I know that this is important, I need to get somebody to help me if I can't go myself. Okay? So, we've talked about, now I need to see, okay, she's sick. What do I need to prepare? You know, airway, breathing, circulation. This keeps it really simple. So she's already intubated. I need to make sure her tube's in the right place, and we're happy with that. It's nicely taped and secured. I need to make sure, from a breathing perspective, I guess she's as optimized as she can be. You know, is there anything I can do to help her make a little bit better progress in that time? And I'm gonna prepare with 2 or 3 oxygen cylinders because she's on 65% oxygen. And when you put patients in the CT scanner flat on their back, often you need to go up on the oxygen. So I need to make sure I have 3 cylinders because I need to prepare for a 2-hour journey, okay? So I'm going to prepare for that. I'm going to make sure my transport ventilator, I'm going to make sure that works. I'm going to set it up, put the patient on the transport ventilator and leave her for half an hour to see how she goes with it. And then my circulation. Does the patient actually need any more fluid? Is there anything I can do to help that circulation? And then I'm going to make sure that my noradrenaline, I've got enough of it, okay, to last the 2 hours plus extra. All right. And then I have to think, okay, you know, I think my patient's as best as she can be, and I have to make the journey. All right. Am I the best person to take her? Or is somebody else better? You have to decide that as well. Okay. So I might think that I can take her, but I also have responsibility for my ICU patients. But I have my anesthesia colleagues or somebody else who is just as skilled to take her is probably better off going, so I can stay in the ICU. So you have to pick the right person. My nurse who's going to come with me, okay, they need to be familiar with the equipment, the pumps, the environment that I'm going to take them in, okay, so they can also look after the patient. We're basically going to be doing mobile ICU around the hospital. So whoever is going, the doctor and the nurse need to be really comfortable. Is everybody happy with that? Okay. So, I talked about you need to know where you're going. Now, if it's in our hospital, most of us have been to these CT scanners a few times, so it's actually a bit more familiar. But if I'm going to another hospital, I've never been to that hospital. I don't know where their ICU is, or their theatre is, wherever I'm taking my patient. And I don't know how long the journey's going to take. So you have to make sure that the other ICU you're going to, or wherever it is, knows you're coming. You know how to get there, so the driver, your ambulance knows how to get there. And that, you know, the team that's over there is expecting you. And you don't leave until you know they're ready for you so that you can make that journey across. All right. So what has happened in the past is you leave and the team is not ready and you're waiting down in the middle of a corridor because nobody's ready to accept you. All right. So we talked about just checking the things about the individual patient. So I've gone through that already. But you want to also make sure if you're going to another hospital that you have got your ward clerks, your admin staff to copy all the notes, to make copies of the scans so you can physically take it all to the other hospital. Because now you're handing over care of a patient to another hospital who doesn't have all the pre-existing information. So you need to make sure you make copies of everything. So the minute you've made that decision, if you're going to another hospital, you have to get somebody delegated to sort out making copies of everything. Okay. Like I said, make sure your tubes, your lines, your drains, everything's nicely secured. equipment. So I think this is probably one of the other most important things. So I've talked about making sure my ventilator works, but I need to make sure I take a spare battery. And if my ventilator fails, have I got another way of oxygenating my patient? Have I got an ambu bag, or a way of delivering, at least even if I run out of oxygen or my ventilator doesn't work, I can still bag the patient with room air. Of course, my patient is going to struggle on room air because they're on 65% oxygen, but I have to still make sure I've got a backup, a plan C and a plan D for my airway and my ventilation. Okay. We often only take the one ventilator. We don't have many ventilators, so nobody takes a spare ventilator. Okay. I've got to make sure my noradrenaline and my sedation pumps, I've got charge on them, have got battery on them, okay, and there's enough drugs. Which drugs am I going to take spare? Emergency drugs, okay. Am I going to take some adrenaline? Am I going to take some extra fluid, just in case drugs? Some just in case drugs you want to draw up and have ready in case you need to give in a hurry. Some others you can keep, you can just take, but you don't need to open the ampules and draw them up and waste them, okay. And that you have to decide. So this is an ICU patient. Oh, it's just lost there. So if this is my sick ICU patient getting transferred, you can imagine how much equipment you've got to look after, all your lines, your tubes, and you've got to make sure that you can put it all on the bed, you can fit in the lift with all your equipment, and you can get safely to where you need to go. That takes a lot of people, okay. It's not a one-man job. Not one person can transfer a patient. At least 2 or 3 of you to take the patient, but then a few people to get them on and off. So we talked about drugs and standby medication. Okay, so I think we've covered that already. I've talked about that already as well. Family. You need to make sure the family know you're sending this patient to another hospital that could be an hour away. Okay. So they know that that's happening. Otherwise, the worst thing they want to do is arrive in your hospital and your patient's not there and nobody told them. Okay. Often, what I would say, so this is what we've talked about, but it's very hard to remember all these things, I'm telling you. We often have a checklist. So in our hospital, we have little checklists for patients who are getting transported to check that you have got all your equipment, your drugs, the right staff, you've communicated with the receiving team, you've got all the notes copied. So you need to make sure that all of that is done. So we have a checklist so we don't forget anything. And I would really advocate that checklists are really important, because sometimes when we're really busy and we've got so many things we're trying to do at the same time, you want to make sure that such simple things are not forgotten. And a checklist is the best way to do it. Okay, obviously if there's more than 1 or 2 of you going, you need to make sure who's going to do what. So usually it's me and a nurse going, and the ambulance is driving me, or a porter's taking me the bed down with me and the nurse to CT, okay? Both me and the nurse, we often know who's doing what, who's going to look after what, okay? So I'm generally looking after the patient's main issue. She's going to manage the drugs, go up and down on the noradrenaline. She's going to watch the monitor. Between us, we communicate before we go who's doing what, okay? And we always know who we're going to call for help before we go. So if I'm leaving my ICU, my team, my nurse coordinator knows where I'm going and knows that she will keep her phone in her hand. We have a phone with us. If we're in trouble, we know we're going to call her, and she will come down or send somebody to help us. So always make sure somebody knows where you're going, and you've got a way of calling for help when you're on the way. Okay. Yeah. So prepare, and then think about what might go wrong. And if you prepare for what might go wrong, it won't go wrong. Or if it does, it's not going to be a big drama. But if you don't prepare for what might go wrong, it's going to be a real shit show. Okay, so you've really got to think, okay, if this were to happen, have I got the right abilities and equipment and everything to sort it out? Okay, and it doesn't mean planning for every eventuality, for the key things that might happen. Okay, and that's usually, like I say, equipment failure, running out of oxygen, suddenly the CT scanner is busy or broken and you're stuck down there for a long time. You know, just figuring out how you're going to manage those things. So I've talked about that, okay? And this is really important because if you're in the middle of an environment that you're not familiar with, you need to get help very quickly. So make sure you've got somebody. And of course, if you are going to a hospital, a different hospital in a different place, you need to check, okay? Especially if it's an ambulance, because that day Zainab said she sent a patient in a helicopter with a huge trauma. Now, if I'm taking that patient in the helicopter, that patient had no face. And I'm telling you, I'm pretty scared taking that. And you have to think, okay, what's traveling in an ambulance? What's the weather like? How shaky is it going to be? Do you get seasick or air sick? If you get air sick or car sick, is that going to be a problem and you're going to not be able to look after the patient because you're just feeling really nauseous, really vomiting? Then you're not going to be the person to go, okay? So think about the environment of the transfer as well. And then, when you've done everything, do your final checks before you're about to leave the door, okay? Which is, am I happy with my airway, breathing, circulation for this patient? And I've been on the transport ventilator for half an hour now. Get my blood gas. Is the patient stable on this transport ventilator? Yes? Okay, I think we can go, okay? So just make sure you go through those final checks. Everybody's on board and you're happy before you move. Yeah, I think I've said this a few times, communication is really important. There's usually, 2 or 3 of us traveling. If we're moving the patient on and off the table, into the ambulance, somebody's always taking care of the head and the airway, somebody's taking care of the lines, the tubes, and then you need a couple of people to just physically move the patient. All right, so clear instructions, really clear communication. And there is no hierarchy here because we're all looking after the patient for the same reason. So it's not that only one person can do this and nobody else can. If some people are better at some things, you've got to know where your expertise is. Okay, this is important. If you are going to another hospital, okay, and your patient gets worse en route, give them a heads up if you can. Get somebody to call because you're busy to say the patient is deteriorated. I'm going to need this help when I arrive. And then when you arrive, don't just dump the patient and go, because now you're a new patient in a new facility who doesn't know them. You've got to stay and help them until the patient's stable, then you can give a really good handover. Now, handover is so important, okay, because you're basically handing over care of the patient. You couldn't be detailed enough, all right? So it's always important to know your patient before you're going. What am I information I'm going to give them? Obviously, I've talked about giving them the notes, and then checking with them, is there anything else, information that you need that I haven't provided? And if they've thought of something that you forgot to bring with you or you didn't know, make sure you tell them, I will find out when I get back and I'll send that information across, okay? But going through the handover is really important, and maybe Ramadan can go through a little bit more detail if he wants about what you want to discuss in a handover. But you want to basically tell the team why the patient came in, what the problem was, what acute issues are, what you've treated, what still needs to be treated, what investigations have happened, and why your patient is arriving in this new place, okay? Okay, so before I actually finish off, I'm just going to say, so obviously most of my transfers are of ICU patients, but I know a lot of you work in the emergency department, and your transfers might be again to another hospital or to another part of the hospital. So Ramadan, did you have anything more that you wanted to add from an ED clinician perspective?
Yeah, we as an emergency physician or emergency practitioner, the perspective of transfer is similar to ICU, but a little bit different because of the patient's acute situation. And all these have to be considered. And there are micro transfers as well. Having a patient on a bed, moving to another bed, that's also a transfer. Things can change. A line can come out, hemodynamic can change. And for that reason, it has to be also to be considered similarly. Is it necessary to move from this stretcher to this stretcher? Is it necessary that having this person to X-ray this time is better than having? Or have you actually have a slot in a CT scan before the patient go? So similar, in emergency department, those kind of things have to be considered. The other thing that I would like to highlight, and has been mentioned by Dr. Rina, is that Can you hear? Can you hear? Okay. So the other thing that we have to consider is, and I think this has been our thing that as we're looking into improving our quality, how we transfer, our history of transferring patients. And I think you're all aware, from one hospital, most of the time here we're doing intra-facility transfers. So intra-facility transfer, it means if a patient is coming from ICU, a patient is better at that ICU. When you move out of that ICU, the patient is in a very bad environment, meaning that the person who transfers that patient should be as equally the same quality or the same level of knowledge of the person who was in ICU. It's not like the same. If my patient is with Rina in ICU or is with Dr. Lugano here, now this person is going to Moi, right? Now you take a nurse who is actually not even an intensive care nurse, a normal nurse, and a driver. Go to Moi. What are we doing? We're degrading care from a highly trained person at Benjamin Mkapa to a person who is not even a doctor, not even having the skill, because the reason is, as Rina mentioned, during transfer, anything can happen. Because of the turbulence of the transport, because of the changing of the environment. For example, sea level is not the same as if you go to high altitude. Similarly, when you're in a road transfer, our roads are not even. So the same thing. So you cannot have a person who is underqualified to transfer a person who is critically ill, meaning that this is where we have to be looking at. Again, a doctor is not designed very well to treat a patient in a moving car. We are not designed the same, meaning that there are people trained, and this is where we can look at having people who are paramedics are actually trained into working in those kind of extreme environment. I don't know if Dr. Rina, you can work well on a fast-moving vehicle.
Not so well.
Yeah.
Well, definitely not thing where but definitely not if I have to intubate a patient. I have to get the ambulance to pull over. You cannot do those sorts of things with a fast-moving ambulance.
So you see, even the best expert, they're not good at a fast-moving vehicle. And this is what the other thing that you all understand where to look at. So a very sick patient, you can't be running at 120, running to the other hospital, because that also put the patient in danger. Anyway, she mentioned a lot of things, and I could say, as long as the patient was admitted in the ward, as long as the patient was admitted in ICU, it is equally important, this patient's care to be of importance when you transfer. And all other things that have been looked at, including the indication, have been exhausted, including the risk and the benefit. Why are we sending somebody GCS of 3? Let's say somebody GCS of 3, and you know, if you call to Moi, there is nothing they can do different. Why are you anyway moving it to Moi? Similarly, it can go down to our lower centers. If there is nothing that can be done differently, why are we moving? Because moving is even riskier. So sometimes discussing with the receiving facility, they may give you guidance, because they will say, okay, that patient, based on how the situation is, I think is better managed there than, or maybe sometimes they can even consider giving you an alternative way of transfer, because some patients are better transferred by helicopter, some patients are better transferred on the ground rather than on air, some patients are better transferred on air than on the ground. So for that reason, then, and with that remarks, I think Rina has exhausted many things. Perhaps you may want to add a little bit and a few questions. Please, Doctor.
I want actually to add some more. You know, Dr. Rama and my colleague, sometimes we evacuate the patient, not transfer the patients, especially for lower facilities. I came from the peripheral regions where the nurses and doctors from the peripherals, especially these dispensaries, they just evacuate the patient because they don't like to stay with patients. And you may find sometimes even the nurse who escort the patient don't know the history of patients. When they came to our area, maybe sometimes when you ask why this patient came, I don't know, they told me to send the patients. It's just 1 week ago when I received a referral from different areas. The nurses came with patient, no cannulation, patient has no catheter, stroke patients. Actually, I was amazing. Even I brought that nurse in my office and talked together so that we can do that one. And remember that our settings, we don't have a complete ambulance. We have the car for transfer the patients. So sometimes if we don't prepare ourselves to transfer the patient, we may find that the patient transfers for low distance, then you get died on the way. So we have to make sure that we know the patient before we transfer. Sometimes we have all equipments needed for our patient to transfer. We normally transfer our patient from Songwe to Mbeya. It's almost 70 kilometers. You may find even the nurse don't have any equipment on the way. Kwa hiyo tuwe makini. Kwa hiyo tuwe makini sana sana. Wauguzi wenzangu, nisisitize sana hapo tena niongee kwa Kiswahili kabisa kwamba wakati mwingine tunapowasafirisha wagonjwa tuwe na critical thinking kwamba this patient kweli anainidi kwenda mahali pengine, ni nini hasa tunachokwenda kukipata. Tunaenda kummaliza huyo mgonjwa au tunaenda kumuokoa. And sometimes these obstetric issues, you may find the nurse and the doctors transfer the patient who has a massive bleeding on the way. How will you resume this patient? How will you make sure that this patient will stop on the way? Kwa hiyo tuhakikishe kabisa kwamba tusiwa transfer wagonjwa wanao bleed. Indeed, it's our protocol in our regions, even the RMOs, say that no transfer of patients who are bleeding on the way. And sometimes the gynecologists, they have to go to the settings and teaching them to capacitate the staff so that they will not transfer the patient to another hospitals without the thinking. Thank you.
Any other comment from the participants? Dr. Zainab, you want to speak something, perspective from Zanzibar, please? Perspective from Zanzibar?
Hello. I think my colleagues have already spoken a lot about patient transfer. And apart in Zanzibar, we are lucky enough, like we have our hospitals nearby. So the similar challenges that you guys are facing, that sister there has emphasizes, we are also facing the same, but we're on the path of improvement. So I'll try to highlight it also in Swahili. Most of the time we panic, especially our junior colleagues. I know when you get a patient who is critically ill and then adrenaline just goes high and you're like, okay, maybe sending the patient to the next hospital will be saving the patient. But unfortunately, most of the times, you're actually handing in a death certificate to that patient. Because as long as the patient is within the hospital, you are more than capable of helping that patient compared to transferring the patient. And we know most of the time we're short-staffed. So the person who is transferring that patient is not really as capable as you are to transfer that patient. So we end up short-changing our patients because we feel like maybe whatever I'm doing here is not good. But maybe that little that you're doing where you are doing will be life-saving for the patient. So again, as what my colleagues have said, we are really emphasizing proper transferring of patients. It's very important. Thank you.
Thank you, Zainab. Some really good points made, and I guess that's obviously something really important for your area and knowing. And I guess it comes down to the first part, making a decision about is that patient benefiting by going or more harm. Okay, and sometimes we have to weigh up the problems, for and against and decide. But it seems like obviously largely there is a lot of harm from transferring the patient to another place. If there isn't anything more they're going to do differently. So you have to really think about it. And everybody's always going to be anxious when you have a really sick patient, and sometimes you think it's out of your depth or capabilities, but I guess that's really a decision you have to make with the team around you.
worked many years in the hospital to have a little bit of understanding. Transferring a patient. You are in the periphery. You want to transfer the patient. Why do you want to transfer the patient? You must have an answer for that question. Why am I transferring this patient? Is it because I can't handle? Is it because beyond me? Is it because I don't have the equipment? Is it because I don't know what is happening to the patient? You've got to have an answer before you transfer. Now, our friends in Morogoro recently, they had problems when they had that tanker which busted and they had a number of burnt patients. And colleagues of mine were saying, this one, Muimbili, this one, Morogoro, this one, Muimbili. So they are doing triage, which is correct. And then came a politician. Are you all right, guys? This man is 60% burnt. You're saying Morogoro. And this 20% to Dar es Salaam. You understand what I'm trying to say? For him, the worst burnt should have been one going to Dar es Salaam. But that's not what trauma says. A person who is 60% burnt, with 60% burnt, is less likely to survive. We don't want to waste the resources on such a patient. Morogoro. Guy with 20% is likely to survive. He goes to Muimbili. The stress is slightly different. So you need to understand what it is. If you put a patient who has a cardiac arrest, you recognize it's a cardiac arrest, and you put him in an ambulance, you're killing him. You're sending him to the grave. He doesn't need that ambulance. We need to decide as to who should and should. If a patient is bleeding, actively bleeding, an arterial bleed, and you put him on an ambulance and you put pressure bandages, you're killing him. Are we together up to there? Think, like what my colleague said. Think before you put that patient on the ambulance. You might be actually killing him instead of saving him. But if the patient is stabilized, and you put him on an ambulance, it makes sense. It makes sense. So don't transfer unless you know what you are dealing with. Don't transfer unless you have stabilized. And don't transfer conditions that usually are lethal, even in the best of hands. Kwa sababu unajaribu kupunguza ile mortality ya hospitali yako. Isionekana wanakufa wengi sana mikononi mwako. Otherwise the ministry will start asking you, why are there too many deaths in your hospital? Peleka Benjamin, mwacha akafe Benjamin Mkapa. The statistics goes to Benjamin Mkapa. The other practical element is the ambulances zetu sio ambulance. Kama alivyosema sasa, za kubeba watu from point A to point B. Namwambia nesi, kumpeleka mgonjwa Benjamin Mkapa. She sits in the front seat with the driver. So who is watching them over the patient? It is happening every day. Not something like that. I'm sure even in your hospital you have seen. The sister sits with the driver. Effectively, the patient has no observations of any nature. There is nobody looking after that patient. The sister is taking a ride. Akifika kule, when you ask the sister, so how is the patient? Does he know the history? Does he know the progress? She can't help you in any way. This is why when we teach trauma in our setting, we teach trauma as if the patient has never been to any medical institution at all. Kwa sababu hata wale wanaokuja na ambulance ni kama vile hawajapitia hospitali yoyote. They are green. They have never seen a medical person at all. So when we are teaching management of traumatic patients, we always treat the pre-hospital one. Pre-hospital care. The first 10 minutes, what do you do with that patient? That's why we are heading that direction, because we realize if you're going to wait until the patient gets to the hospital, the patient is decompensated or already dead on arrival. So let's take this matter very seriously. It looks like it's a very simple lecture, but it's not. It's not a very simple lecture, because it's got a lot of stuff in it. And there will be politicians who will come and harass you for not sending or for sending somebody to another institution. You've got to have answers for the politician, and for me, answers for yourself. Why are you sending this patient away? Maybe like Dr. Rama says, the patient is better in your hands than in the next hands, pair of hands. I can continue.
Thank you very much. Okay, I think we'll end the session there. Very good. Did you want to say something, Maynard? Okay. Well, we finished, but you've got 1 minute.
It's a deep subject. Point out a few of the things that actually you need to go deeper in it. Number one, I had a discussion with one of the flying doctors in here concerning a patient on a mechanical ventilator and a patient with on oxygen cylinder. Which one will have more oxygen consumption? And I actually told him that there's a formula for that. There's a patient who can be on a mechanical ventilator with a FiO2 maybe of 50%, and you have a patient with an oxygen cylinder maybe 15 liters per minute. The patient with oxygen cylinder 15 liters per minute with the first mask reservoir will actually use more oxygen compared to the one on a ventilator. So there's a formula for that. You can consult me on that. So it used to be a very challenging issue, especially during the COVID times, because we had people transporting patients far away from all the regions to Dar es Salaam on oxygen cylinders, and they used to end up on the way, running out with oxygen on the way. Yeah. So if you're not well prepared with a lot of calculations on how to transport your patient, it's going to be challenging on your journey. Yeah. Another thing, something that maybe some of you might actually not recognize. Sometimes patients arrive at hospital, they are dead. Meanwhile, during the transport, they were alive. So you see, there's a bit of physics to it. Third law of motion. To every action, there's an equal and opposite reaction. So now, for example, you have different patients. For example, you have a patient who's hypertensive, a very hypertensive patient. Maybe you might need some vasopressor to actually support the patient. So you have your ambulance. So the patient is sleeping in the head is actually, the patient is like this and the ambulance is like this here. So the head is, the legs are facing towards the door and the head is facing towards the driver. So you have this ambulance going like this. So this is an acceleration motion, yeah? So this is the motion going like this. So the opposite motion will be going backwards, yeah? So now you have an ambulance with a 120, yeah, speeding up. So going like this, the opposite motion will actually be displacing organs and blood and fluids to actually opposite to how the ambulance is going. So the car is moving fast, and now everything is moving backward fast. Yeah? So you have your blood pressure, your blood flowing, going away from the brain, going towards the legs. You understand my point? So now you are decreasing perfusion of your patient towards the brain. Everything is being displaced towards the legs. And now you have an hypertensive patient who is actually deteriorating more with an ambulance that is actually going very fast. Because drivers know that an ambulance needs to go very fast. But that's not the point. An ambulance just needs to have a steady motion, a constant motion, maybe like 60 kilometers per hour. Now, the same applies that whenever an ambulance decelerates really quick, when it goes like this, and then it decelerates, so now you have another opposite reaction. So now your organs and everything is dispersed towards the patient's head. So you're predisposing your patient to the risk of vomiting, aspiration, increase in ICP, especially when you're transferring a patient with a brain injury. So eventually, the way you're transporting your patient with an ambulance, that you're speeding up and going back and forth until you reach the hospital, the patient is dead. And you actually don't know why that this patient has died. So those are some deep topics to it. And as Dr. Fire said, that it's a very deep topic. We really need to stress upon this. Thank you.
Thank you. Okay, we're going to close the session here now. So I think the nursing group are going to carry on with their teaching that they were doing. I think they're halfway through nutrition. So if you want to head back to your little room, your big room, down in the training center, and we'll doctors group back into our training center as well for some workshops. Okay. Good. Thank you.
Let's use 5 minutes, guys. 5 minutes. Hivyo tutamaliza haraka. Tunakuonyesha tunabakia kama session mbili tu tumalize. So, mwende moja kwa moja kwenye training yenu kamalize ili mwende nyumbani mapema. Go home right?
The Same Qualities Foundation kwa kushirikiana na hospitali ya Lumumba Zanzibar wanakuletea upasuaji wa midomo wazi utakaofanyika bure kabisa. Ni kuanzia tarehe 7 hadi 11 Aprili. Mahali ni hospitali ya mkoa ya Lumumba Zanzibar. Mzazi unaomba kumfikisha mwanao hospitalini hapo siku moja kabla ya kuanza kwa zoezi la upasuaji. Kwa mawasiliano zaidi tupigie simu nambari 0776 177 742 au 0738 229 449 na 0717 531 312. The Same Qualities Foundation, hatua moja, tabasamu moja. The Same Qualities Foundation kwa kushirikiana na hospitali ya Lumumba Zanzibar wanakuletea upasuaji wa midomo wazi utakaofanyika bure kabisa. Ni kuanzia tarehe 7 hadi 11 Aprili. Mahali ni hospitali ya mkoa ya Lumumba Zanzibar. Mzazi unaomba kumfikisha mwanao hospitalini hapo siku moja kabla ya kuanza kwa zoezi la upasuaji. Kwa mawasiliano zaidi tupigie simu nambari 0776 177 742 au 738 229. na 0717531312. The Same Qualities Foundation, hatua moja, tabasamu moja. The Same Qualities Foundation kwa kushirikiana na hospitali ya Lumumba Zanzibar wanakuletea upasuaji wa midomo wazi utakaofanyika bure kabisa. Ni kuanzia tarehe 7 hadi 11 Aprili. Mahali ni hospitali ya mkoa ya Lumumba Zanzibar. Mzazi unaomba kumfikisha mwanao hospitalini hapo siku moja kabla ya kuanza kwa zoezi la upasuaji. Kwa mawasiliano zaidi tupigie simu nambari 0776 177 742 au 0738 229 449 na 0717531312. The Same Qualities Foundation, hatua moja, tabasamu moja.